everybody. Welcome to the afternoon breakout session, just to make sure that you're in the right room. You are in the behavioral health session titled Pioneers of True Integration, Behavioral Health and Value-Based Purchasing. You'll get to hear a little bit more about that, what that means, from our three presenters who we have up front. Dr. Sylvia Rowlands from New York Foundling, we have Dr. Judith Feld from MVP, and we have Chris Copeland from, help me, ICA? ICL. Sorry, they gave me notes and I don't follow script, and this is what happens. I'm actually not going to go into much detail about who the folks are. You'll learn from their presentation. Chris came from New York City through the snowstorm this morning, and Judith from Buffalo, so the more time I can give them to speak, the better we all are. So with that being said, Sylvia, go ahead.
Fantastic. Thank you all for inviting me and allowing me to speak. I think this, I have to say to you, I was pretty overwhelmed having heard the folks speak upstairs and all of the details and all of the things that one has to do in order to get all of this stuff together, and I thought, oh, I'll take it down a notch, and so I'm just going to do integration value-based payment for dummies, so I can like really feel like I'm in my element. I want to just do a quick survey though in the room out behavioral health providers. Oh, yay! Okay, so we can like really talk.
How about non-traditional behavioral health providers? Does that work?
Oh, non-traditional behavioral health providers?
Yeah,
Sure.
meaning that you do behavioral health without, not in a licensed setting.
Sure.
So you're
Okay.
a CBO.
Like yeah,
Oh, you're a CBO.
that does a lot of behavioral health work.
Absolutely.
Yes.
Absolutely.
You're
Fantastic.
Couldn't figure out which room to go to.
Right, no, you're in the right spot. Right. So let's do that one then. Let's do CBOs in the room. Okay, fantastic. Okay, fantastic. So like level 3 or tier 3 CBOs, billing Medicaid and straight up CBOs. Okay, fantastic. Primary care providers. Welcome. Thank you. How about any folks who are actively in a value-based payment arrangement?
Pilot.
Okay, pilot. Oh, better yet. So this is really a beginner's group. What did he call it? We're still in the planting?
Planting phase.
Planting phase, yep, so in the planting phase. Okay, fantastic. My name is Sylvia Rowlands. I am the Senior Vice President for evidence-based programs at the New York Foundling. The New York Foundling, let me advance on my slides. I'm really, really bad at this, so I will try to pay attention to all my slides, all 30 of them. I'm the Senior Vice President for evidence-based programs, and I've been at the New York Foundling for 15 years. The New York Foundling has been in existence for 150 years, and we are probably one of the best-known child welfare agencies in New York City. We are the largest preventive care provider, so I'm speaking to the CBO world. We are one of the largest preventive providers in New York City. And preventive care in New York City is a little bit different than it is in upstate New York, I believe, because we are contracted by the government agency to deliver the services that prevent kids from going into foster care. We are one of the largest foster care providers in New York City, so we have just about 1,000 kids in foster care. I'm going to show you a cool slide in just a minute.
Don't do foster care.
Okay. And we are one of the largest juvenile justice providers in New York City. So we take kids off Rikers Island, we take kids out of used to be LCFS placements, close to home placements, and get them back home. And we are one of the largest behavioral health care providers in New York City. So we serve strictly family. We don't do individual and we don't do group work with families, and we serve about 7,000 families a year, which equates to about 28,000 to 30,000 lives covered from our agency. I want to talk to you a teeny bit about, so when I was listening upstairs, I was hearing them talk about, collecting data, and for folks in the behavioral health world, I know, and I can speak only for New York City providers because I'm a member of the directors group for the city of New York, and we talk a lot about data collection, and it's a very confusing for a lot of us to figure out what our goals are, how we're going to track on those goals, what should we be aiming for in our data collection, and and I want to talk to you about how Foundling has found a way to make that kind of easy, and I hope that it will offer you an opportunity to hear about how it might be easy. Over the last, so we've been in business almost 150 years, served 27,000 individuals last year, and for the last decade, here's what our outcomes look like. So we have 20% of our families do not complete treatment, and we move them on to something else. 78, 79% of our families complete treatment in 6 months, and the treatment is sustained. The outcomes are sustained for, we've tracked many of them out 3 years and 6 years. I want to talk to you about the issue. So I want to talk to you about the issue that brought me here today, and I want to start with the why of why I do the work that I do. I listened to Simon Sinek on my way out running this morning, and I was listening to the people don't buy what you do, they buy why you do it, right? People don't buy what you do, they buy why you do it. And so I want to tell you why I do it, and I'm hoping that you'll buy some of what I'm talking to you about, because you know what we do. You know how we do it. We all do something similar, but I want to talk to you about why I do it. I was a psychologist in residential placement. That's a euphemism for jail. For kids ages 12 to 17. They were violent youth offenders. They were sent up from the city of New York to upstate New York. 376 miles away from home is the facility that I was a psychologist for. And we were the cutting edge facility. And we were driven by science. A university professor came up and taught us what to do from Maryland. We followed exactly what she said to do. It's called model adherence. She said, you see them this many times when they first come in the door, you do this paperwork, you follow them like this, you go to their homes and see their families, you do all of these sorts of things, and you will get better outcomes than what the service as usual. And I don't know if you know service as usual for New York State residential placement, but in 36 months, 82% of them are rearrested, 45% of them are reincarcerated, and they spend 75% of their adult life in corrections, right? So, whoa, right? Whoa, 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 whoa. I don't think an investor would pay for that. It's certainly not a value-based payment, anything. So she told us to do this. We did this. They did a study on us 10 years later, and we had 92% of our kids arrested. 50% of them were incarcerated by 36 months, and 91% of them were in corrections for 75% of their adult life. It was a horrible outcome. And the other piece that happened along with that at about the same time is there was some research on siblings and juvenile delinquents. And 62% of siblings penetrate the system. Right? So not only did I have to bear the karma for 92% of those kids who spent their adult life in corrections, I then also had to deal with the karma for 62% of their children, of their siblings who penetrated the system. So when I tallied it all up, I probably was responsible for the damage of 14,000 children's lives. So the why I do this, and the why it comes across with the energy with which I'm delivered it to you, is because I've got a lot of karma to pay back, and I am, right? And I went home on the day that we got the data on the research, and I was beside myself because I love that job, and I put my heart into that job, and I went and saw every single one of those children's homes in New York City in the Albany projects where the OG was standing in front of the door as I walked through, right? So I committed myself. I lost a bunch of my children's lives because every holiday I had to do a mental health assessment on half the kids in the facility who wanted to kill themselves because they were there at Christmas, and they were there at Thanksgiving, and they were there at Easter, and all of the holidays when they didn't want to be there. So I was devastated. And I went home to my oldest son, and I said, what am I going to do with the rest of my life? Like, how do I do this? Data is great. Data is the looking glass to the future, right? So had I had the data, and you know what? I really didn't know. New York State had already run 22 outcome evaluations on kids in jail, and we already knew 82% of them failed. So when they brought us the new facility, the new plan, I was like, it's got to be better than what it was. No, it was worse. But anyway, so we knew. So my son said, you'll find something, and I happened to step into something called evidence-based practice, and I do want to talk a little bit about that, but I'm being mindful of time. So if I don't get to during the conversation, please ask me, because I think that if you haven't been collecting data yet, it's okay. because these folks who have done this evidence-based work have already collected 30 years of data for you. So you could start today, in 6 months, be ready to start selling what you do to a managed care organization because there's 30 years of randomized control trial data behind some of this stuff. So we'll talk about that in a minute. But the issue that I'm here today to talk about is that right there. That's why we have that, right? So look at it again. Less than 1% of all government spending is based on impact. That's horrifying, right? That's why we have to go here. Less than 1%. The issue is less than 1%. The why we're in this, I think, is to help here. Is to help the spending be based on impact. I've been a mental health provider in New York City. I've been a mental health provider for 30 years. In New York City, the average or the modal number of visits to a mental health clinic by a teenager is, anybody know? Got a guess, anybody? Chris Copeland knows, 1. 1. And you know what? We have never been defunded. We know what happens when you give adolescents individual therapy, especially if they're depressed, especially if they're juvenile delinquents. We know what's going to happen to them. The outcomes are worse than the problem. We know that. Less than all of our spending. We've never been defunded. We have a 47% no-show rate. Most of us in New York City. We have never been defunded. Less than 1% of all the government spending. So I want to talk about, so this is the good news, right? So here's an evidence-based practice that's called functional family therapy. Here are the benefits. So here's a brief summary cost, $30,000 for a contract with FFT to come and teach you how to do this. Here's the costs. This is an Oregon cost. No, it's not. It's a Washington State cost. So this is data pulled from the Washington Institute of Public Policy. And so you contract with FFT for $30,000. It costs per person about $3,000. Look at the benefit. And look at the cost-benefit ratio and the probability of getting that cost. How do we know are getting that benefit? So for every dollar you spend on an FFTCW therapist, you get an $8.92 return on that. Outcomes are better. Longevity, the sustainability of the treatment is better. Your staff stay longer. The taxpayer benefits from this. Guess what else? There are no wait lists or wait time for treatment in my clinic because every 6 months everybody's turning over. We have no wait time. We have no wait time for psychiatry. So, as I said before, so data analytics, evidence-based practice, research data. That's our modern-day crystal ball. So I just want to show you what's the impact of doing this predictable, data-driven, research-driven work in New York City. Here's the juvenile justice placements. Look where they are now. I had a small piece of that. I kept 400 kids. In 4 years, I kept 247 kids out of placement in New York City, and the savings to the city was $35 million. They didn't share the savings with me, right? But that was the savings. So we used to have 1,000 kids. In 2007, there were almost 1,200 kids in residential placement in upstate New York. In 2012, there were under 400. In 2017, there were 142. Calculate the savings of that at $227,000 a year with an 82% failure rate. Here is a small functional family therapy behavioral health intervention for kids and families who have a psychotic disorder, have an emerging schizophrenia, have the serious, well, in the adult world we call them SMIs, in the kid world we call them SEDs, but we also then took only kids who had 5 or more hospitalizations or ED visits in the 9 months leading up to their referral to us. So here were the numbers of admit days and ED admits and psychiatric hospitalizations before they came to us. Here was during treatment with us, which is an interesting thing to look at, right? So we don't generally in research look at during treatment with us because we're working at trying to fix the problem. So the problem wasn't completely fixed, but so here's this. Please note this number right here is an interesting number. So we had more psychiatric placements than they did before they came to us because we had planned placements for med stabilization. And then look at 6 months out. And the variance is against the pre-treatment data. And then here is 365 days out. It's got to stick with it. You know how long it took that? You know how long those treatments were? 4.7 months. Entire family. So not only did we impact the IP, but we impacted every child and adult in that home. And interesting around Medicaid is that, and commercial health, is they can't give us the information for a family. So this is strictly savings on an individual in a family-based treatment who about a third of the families, or a third of the adults in our service had the similar psychiatric disorders, and about a third of them had substance use disorders. So we treated all of those things in addition to the IP. And then look what happened to New York City foster care. It went from 16,000 kids, 17,000 kids in foster care to, in 2007, so today, there's less than 9,000 kids in foster care. We implemented a menu of preventive services that had years and years of research behind them, and we're able to change the system dramatically. I'll skip to that, but I want to show you this one. So the change in foster care resulted in a mental health and medical per diem rate for all foster care kids to this degree. So what's the importance of this? Right? Investing limited resources where there's no ROI. We do things that don't work. This is Scared Straight. Right? You still see it played on TV. Right? So you take a kid who's a juvenile justice kid, a delinquent kid, you put him in a prison, and the folks in the prison act crazy and try and convince them that they shouldn't be there. The total benefit to the taxpayer and everybody is minus $13,000. It costs more to do this intervention. There are blue chip. We talked about that. There are blue chip social investments with proven ROI. Multisystemic therapy you've probably heard of. Functional family therapy. There are 3 adaptations in functional family therapy. One is a behavioral health adaptation. One is a foster care adaptation. One is a child welfare adaptation. The child welfare adaptation in functional family therapy, 3 years out for 6,000 families show that they're 82% less likely to have a re-indication, repeat maltreatment. 3 years out, 6-month intervention on families who had on average 8 indications coming in. These things are powerful things. They're things that insurance companies love to see because you bring with you 30 years of data. There are about 350 implementations around the world of FFT or MST. FFT and MST collect that data, compare it against your practice, and advance it to you so you know where you stand in the world, you know where you stand against your own numbers. This is the benefit. We already talked about the FFT's benefit to cost ratio. Here's the can you build a value proposition. I think any of us could build a value proposition when 365 days later in a 4.7-month intervention, the highest utilizers in the Medicaid system are 100% less likely to have another psychiatric hospitalization. They are 73% less likely to have an ED visit. They are 91% less likely to have an inpatient or residential stay, and they're 82% less likely to have an admin. Here's the one that I told you about, the 4 years on a small intervention, keeping kids out of jail, was able to save $35,928,360. I'm talking a lot about money, but I hope you all, I'm sure you all know that the money is driven by the personal outcomes. So we don't have kids going back into care. We don't have kids going to the emergency room. We don't have kids being hospitalized because their symptoms are controlled, because their families are able to control the symptoms lifelong. One of the studies, an MST study on kids who were served with MST 25 years ago, show that 25 years later, the families are less likely to be involved. They're less likely to have divorces. Their children are less likely to be involved in the systems. So engaging MCOs, am I up for time?
Yes.
2 minutes, okay. How do you like that? Yeah, okay, beautiful. I'm gonna leave engaging with MCOs to Chris Copeland, who's going to talk right now about their pathway to from a social service system to a value-based payment pilot.
Good afternoon. I think we're going to prove when you've seen one healthcare behavioural health provider, you've seen one behavioural health provider. I think me and Sylvia couldn't be more different, perhaps, in our approach and presentation. But it's really hard to follow something like that in terms of the amount of detail and the amount of evidence behind it. But what I'm going to try to do is talk a bit about how ICL, I'll explain who we are in a minute, progressed from being probably thinking of ourselves as a social service provider to being part of an integral part of healthcare, which is, I think, the journey that behavioural health providers and, I would argue, CBOs need to make to be able to enter into value-based purchasing arrangements. We can't sit outside the system and hope that we're going to be brought into the system. We have to rethink who we are and how we operate to have and again, that idea of a value proposition that MCOs or healthcare providers are interested in. So that's what I'm going to try and do in a few minutes. And I've got 4 slides and a few words. And again, it's very different from Sylvia's presentation. And I think maybe that's nice, the sort of the yang of the two. ICL is again another New York City provider. We're fairly large. We are in all 5 boroughs, and our service delivery ranges from residential programs, case management, providing people with support in supported housing, to congregate care facilities, to shelters, to outpatient treatment facilities, ACT teams, health homes, and we also have a division that serves people with intellectual disabilities. Apart from the ACT teams, I don't think that we provide any other services that are actually evidence-based. A lot of what we do is probably what a lot of what other providers do, which is provide services that is more practice-based evidence than evidence-based practice, if you see what I mean. So we started, I think, beginning to think ourselves differently than a social service provider. I've been talking for a long time about what we are as a healthcare provider. And I'd argue that's true of CBOs as well. I've only begun to hear the phrase CBO recently, and I'm beginning to think it's a pejorative term for everybody that doesn't provide healthcare. Now, what I'd argue is that what we do is provide treatment services. Now, maybe that's supported housing, maybe it's providing air conditioning to somebody who has asthma, which is what, in terms of CBOs, providing the interventions around social determinants. It's all treatment for conditions. And I think beginning to think like a healthcare provider rather than a social service provider is really critical. So we need to start thinking about outcomes rather than hope. A lot of our mission statements say we give hope to people. That's great. What we've changed our mission statement to, or our guiding principle, is people get better with us. Because it's not good enough just to say, well, come to us and we'll give you hope. That's a social service provider. We actually want to get people better. And we provide treatment. Supported housing is treatment for people with severe mental illness. So beginning to think about ourselves as a healthcare provider was almost like step one. And maybe everybody in this room is here with that. The second is that really understanding that the major problem facing people with behavioural health issues is not their behavioural health issues, but their physical health issues. We all know that the people we serve are dying young because of physical health problems, not because of behavioural health issues. So we're not going to solve those problems by creating a better behavioural health system. And I'm pretty sure that the healthcare system isn't going to change enough to begin to provide healthcare to people with behavioural health in the near future. waiting rooms and long waiting lists and 5 minutes with a primary care practitioner doesn't really answer the needs of somebody with a serious mental illness. So we need as behavioural health really need to think about how can we take ownership of that and think about how do we provide healthcare interventions for people with behavioural health care around their healthcare, not necessarily not excluding their behavioural health care, but about their healthcare. So that was like step 2 for us. We are a healthcare provider that if we're working with people with serious mental illness, it's about their total healthcare that we've got to be paying attention to. So we've been working for a number of years around integrated healthcare. How do we do blood pressure screening across everybody that stays with we have about 3,000 people who stay with us every night in supported housing or shelters. How do we think about blood pressure screening? How do we look at those healthcare indicators that for a lot of the people we work with, they're life and death. So that became really very important for us. The third is beginning to realign ourselves with, I haven't done this, have I?
Yeah.
Oh well, there we go. Just what I'm saying, don't worry about it. So really thinking about addressing ourselves as part of how do we align ourselves with the high cost poor outcomes of healthcare? What role does behavioural health play in that? And I'd argue that we play a key role. That healthcare, the MCOs and the PPSs and the healthcare providers are trying to tackle very poor outcomes with very high costs for people who have behavioural health issues. Now maybe this is serious mental illness or maybe it's serious trauma, but whatever it is, without addressing that, which is our speciality, without addressing that, people are going to continue to have the same outcomes. Now maybe what we can do is provide more and more better evidence-based practices, but there aren't, for somebody who has a serious mental illness living in supported housing, there really isn't a evidence-based practice. There are for certain cohorts, but for a lot of what we do, I don't think there are those evidence-based practices. So what we've tried to do is think about how do we and agencies that deal with social determinants, how do we intervene within the healthcare system? What is it we can provide to both managed care companies and healthcare providers that makes a difference? So we started talking to MCOs. So I've put members next to MCOs. Part of the trick is begin to learn the languages of our partners. So I don't talk to MCOs about consumers or clients, I talk to them about their members. And what can I bring to those MCOs that they need to tackle? And what their issue again is high healthcare costs, poor outcomes, but really the high healthcare costs. And I heard upstairs this need, somebody asked a question about data. And the answer was one I couldn't understand because it was something to do with multi-data, something maybe 2 years ago. We now have 2.5 years worth of data about all our programs and all our clients, and it's self-reported, but we've been able to cross-reference it somewhat with some claims data, and it's fairly accurate. So we're now able to show reductions in ER visits and hospitalizations for physical and psychiatric reasons across the whole agency, across all programs. So I can now walk up to an MCO and say, we run ACT teams and we can reduce the use of ERs and hospitalizations by 50% of anybody who comes into our ACT teams, or pros or supported housing or whatever. So this wasn't difficult. This was simply putting into the treatment plan, review every 3 months or 6 months or whatever it is, that question, and then capturing it somewhere and running reports on it. So this has been, and I don't know that these outcomes are any better than anybody else's, but I know other people who haven't got these outcomes, so I'm one step ahead of everybody else because I can show them. And what that does is show to the MCOs that we're really, really interested in outcomes and data and not about just providing more and more services. So I'm able to have that conversation with MCOs based on those outcomes. And we all know, we're open about these are self-reported, but at least it's an open discussion about that. So the next area was developing relationships with healthcare providers. So they have patients. We have clients, MCOs have members, they have patients. So the way we develop relationships was the work you're doing here around districts and PPSs. And relationships. I heard it upstairs, and I think it's the only reason that we're now involved in 1 or 2 VBP pilots is because of the relationships I developed with somebody who's in a healthcare provider within one of the PPSs in New York City. And we began talking, so this is Mount Sinai PPS, it's the head of the psychiatric services within Mount Sinai. And we began a conversation about, we know we have some horrible outcomes between Mount Sinai providing inpatient care and some ambulatory care, and ICL providing supported housing and treatment facilities. We own the system. And unless we're prepared to work together to change the way we interact with people, people are going to keep failing. There is nobody, essentially we said there's nobody else to blame but ourselves. So we really need to think about what are we going to do together and jointly own that. So that was the relationship building. We ended up talking about the new home and community-based services as a way of trying to engage people who have very high Medicaid costs. These are folks who have average $30,000 spend in Medicaid, and much higher than everybody else. These are people completely disengaged from treatment services or preventative treatment services. And we said to each other, why can't we use HCBS services, not as a behavioral health intervention, but as a healthcare intervention? So that was the key to the discussion with the healthcare provider. I wasn't there saying, we want to help these people with behavioral health issues. We said, we know we have behavioral health people, clients, members, consumers, people who have very terrible health outcomes and in your ER all the time. Let's use HCBS services to provide healthcare interventions around their asthma, around their use of ER, about their education needs, about whatever HCBS services can provide. So that was the key to being able to develop a VBP. And so essentially what we ended up in was a VBP pilot, which is the HARP, the Health and Recovery Plan Total Cost of Care pilot. And with Mount Sinai and Health First, we now have a VBP arrangement looking at the total cost of care of HARP members who are enrolled in Mount Sinai's physician org system and involved in their health home. It's around 2,000 people. Their total cost, 2,000 people times $30,000 is, I forgot the number, it's about $60 million a year of just these 2,000 people. It's an enormous amount of spend. And as we've begun to engage, this is a level 1 upside only. So the contract that we developed was that the way that we may have some payment for this is adherence to reporting on metrics, plus if there is any reduction in the total healthcare costs of this population, we get to share some of that. Now our contract is with Health First. We're still getting paid on a fee-for-service basis for the home and community-based services, but if the pilot between Mount Sinai, Health First and us saves money on the total cost of the HARP, of which the HCBS is only part, that's where we begin to share. And to be honest with you, this is only working through, we're now probably 2+ years into bi-weekly meetings talking about how do we get the Mount Sinai's health home to be able to engage people, talk to Health First, get an approval that can be sent to us within a very short space of time, because I think it was taking like 3 months to get an approval for HCBS services. So we came up with a system that could do it within a couple of hours. It's never really worked that well, but if everybody, the patients, consumers, members would cooperate, we could get somebody to an emergency room within a very short space of time. The health home care coordinator could assess somebody, call Health First, who would agree, then they would call us and we could get there. So that's the sort of commitment to work together to try and make a difference. It's an incredibly slow process. We probably after 2 years have something like 20 or 30 people who are enrolled in home and community-based services who are Mount Sinai patients. But it is still an enormous change in the working relationships between those providers. And just finally, if I can answer, these are the metrics that we're being judged on. And as you can see, a lot of these are not behavioral health metrics. because that's not what's important to this heart population. It's the fact that they're dying of cardiovascular disease and diabetes early. That's what the real issue, so that's what we've been judged on. We're trying to change those. So my home and community-based service staff have not only the instructions to engage people, but also you've got to get them to the primary care practice to get their flu shot. You've got to make sure they get their A1C levels done. That's what's very being able to appeal to both the MCO and the healthcare provider, not as a behavioural health provider, but as a healthcare provider. Now that may seem maybe obvious to everybody in the room, but it took us a bit of thinking that we need to change who we are and what we're doing to be able to do that. And I can tell you what we've discovered. I don't know how much time I've got left, but what we've discovered about the folks who are home and community-based services is they have high Medicaid costs for a reason. These are incredibly disabled people with very, very serious social determinants within their life, with terrible outcomes, and not many of them have Axis 1 diagnosis. Not many of the people we're intervening with have schizophrenia or bipolar. These are mainly people who have not adjustment disorders, but PTSD, huge amounts of trauma, people who only use healthcare on their own terms, which is often not at the time that we like, but the time they need, and often they won't go out of the house. A lot of people we're intervening with just won't leave the house, so their healthcare is only in emergencies. So we're bringing healthcare into their home, and again I emphasise healthcare rather than behavioural healthcare. So that's our journey, and I hope that's helpful in terms of how we changed who we are to become more part of the healthcare industry rather than a separate behavioural health. I'm worried that if we as behavioural health providers sit outside the healthcare system's going to get fed up with waiting for us to come in and develop their own services, and over time begin to put us out of business, because I know hospitals and healthcare providers, I've experienced this somewhere else, start their own services because they're fed up with our delay in services, long wait lists, can't get people in, 47% no-show rates, etc., etc. So I think it's critical that we begin thinking this way. There you go. Thank you.
Great. That was great. Okay. So thanks. That was excellent. And how you arranged this was perfect, because I'm going to be building on that.
Yep.
So I'm Dr. Judy Feld. I am currently the VP for Behavioral Health at MVP. Relatively new at MVP, came in last year because MVP is really changing their vision on how behavioral health gets integrated into medical care. Just a little bit about my background. I'm a psychiatrist, and I was a provider for over 20 years. And what got me onto the payer side is that I got fed up with my patients not getting the care they need. I was diagnosing diabetes, I was picking up cancers. That felt good, but it didn't feel right. And my patients were stigmatized, they were not integrated into medical care, and this made no sense to me, because this was health care. Why is this different? So got into the payer side of things, and it's really been terrific, because there's really an opportunity here to impact our patients and how we deliver care. I don't think there is a better time in healthcare since I've been around, and I've been around a little bit. I'm not going to tell you how long. But this is really the time where behavioral health shines. When I came out of medical school, I was the black sheep. Now I have a really important chair at the table with everybody else, because finally there's a realization that behavioral health is the hidden cost driver. And we may be paying 5% of our healthcare dollar on services, on all we spend, but if you look at all of the secondary and tertiary results of not taking care of behavioral health, you're getting into a much higher spend, right? So does everybody know about the American Psychiatric Association Milliman report, commissioned in 2014, found that patients with comorbid mental health disorders, they looked at the most common chronic primary care conditions, everything from COPD, asthma, heart disease, end-stage renal disease. They looked at all sorts of chronic conditions and compared them to, took people without diagnosed mental health substance use problems and then compared them to population that did. And this was a huge data retrieval. So over 3 years, I think it was 2012, that they finished this. And they found the costs were 2 to 4 times higher for patients who had chronic medical illnesses and comorbid mental health problems. We ran the same exercise at MVP with our mental health members and also our medical folks who did not have comorbid mental health problems. We had the exact same finding, 2 to 4 times the cost for medical care for patients, members who have comorbid mental health problems. So yes, managed care is very interested in this, and the way to deal with this is through integrating mental health, behavioral health into medical care. I live in Buffalo, but I work at MVP. We cover Rochester all the way through Schenectady and up to the Capital District. When I was in Buffalo, I also worked with Independent Health and did a lot of work on integrated care in primary care and found tremendous results when you integrate care, behavioral health care, into primary care. So it's really changing how we do business, how we deliver service. We are becoming part of the healthcare continuum, and value-based care is where we're going to shine because we're going to bring tremendous value to healthcare. So I'm going to talk a little bit about a pilot we are going to be starting because this stuff is really new. And then I'm going to follow up with just a few minutes of lessons learned and why I think this really is an opportunity for behavioral health to shine and to really be a promoter for the success in value-based payments. So right now, MVP, just to give you a little background, has a partnership with Beacon Health Options, Beacon Health Strategies. That partnership has been in place for a number of years. And one of the reasons I've joined MVP is to really start changing that relationship. So integrating with Beacon much more strongly and really start tearing down some of those silos. And Beacon has an IPA of our behavioral health providers. And so we are contracting with that IPA and have decided to go into a value-based contract with Beacon because of this basic theory that it's really behavioral health that drives our medical expense. And so we are also going to be working with the HARP population. And I think one of the reasons we focused on HARP is it's an easy way to collect data. It is a targeted population, and as everyone knows in this room, a very high need population, right, with tremendous expenses and tremendous medical expenses. So if you look at the medical expense for a HARP member, yes, they're expensive on the behavioral health side, but they're really expensive on the medical side. That's where you're really going to cut your costs. And what's driving that medical expense? A lot of it's their untreated or poorly treated behavioral health problems. And we all know that this population dies 17 to 25 years earlier, and we know it's because of their medical care. So we have a little bit south of 5,000 HARP members, and we said to Beacon, look, you just do behavioral health, we've been doing a lot of medical care, let's get together and start blending this. So we're in a value-based shared risk contract, a level 2. So there's up and down risk. I just want to have a caveat, I can't get into a lot of detail on this because we have submitted the proposal to the Department of Health and we're waiting to get blessed. So until we do, I can't get into a lot of detail. But the framework is interesting because I think it really speaks to what Chris is talking about. We have an assigned targeted population, and we're really looking for quality and efficiency improvement. So we're looking for shared savings. If we can deliver good care and there's, we find efficiency in that. We all share in it. If we find that we're not delivering good care, we all suffer some of the losses, and there's caps on that. We're doing it very, very thoughtfully. But the important thing is there's a quality gate. Nobody wins if the quality is lousy. So you build in a quality gate, and we're using a number of the measures. Actually, New York State has come out with measures specifically for HARP, both behavioral health and medical measures. And we are working with Beacon on the behavioral measures because that's where their core competency is. But we're saying, but you're still responsible for medical measures too, and we're going to be working very closely with you. So we're really changing how we're looking and treating a population with this comorbid dual presentation. What the result of this is we've come up with really innovative ways to care manage, to collaborate. Our work with Beacon is becoming much deeper. We're trying to figure out, how am I going to understand the medical expense? How are we going to communicate that? How are we going to share data? We've got behavioral health people who are far more interested in what the medical concerns are. And then we've got the medical folks who are looking at behavioral health much differently. And this is what a value-based contract supports. We are also, you have to, with a level 2 risk contract, you have to contract with a CBO. And it makes a tremendous amount of sense because social determinants drive so many of the problems in behavioral health. And everyone in the room knows this. I mean, what's the number one mental health intervention for the seriously mental ill? It's housing. So we have contracted with a CBO, and together between CBO support, Beacon, and MVP working closely together, we're hoping that we're going to see a very different outcome for our HARP membership. So just to enforce the fact that the total medical expense of members with a diagnosed behavioral health illness is 2 to 4 times greater than for members without a mental health or substance use disorder. And the increased expense is seen in the medical services category. If we're not looking to cut costs in behavioral health, in fact, we anticipate costs will go up, but we want good interventions, evidence-based interventions, that will really impact the member, because if your behavioral health costs go up thoughtfully, your total medical expense comes down. So it's not about cutting behavioral health services, it's about refining them and doing what works. So the linchpin for taking risk in value-based programming for behavioral health providers is efficiency. Now, we use that word a lot for cost, but I'm really talking about efficiency in delivering care. Size matters. It's really hard to do value-based work with smaller agencies and smaller networks. You really need to partner. You need to partner with community-based organizations, ACOs, large FQHCs. Partnerships are really important because in order to take risk, you need a big enough population to make it work. Think hub and spoke. So I don't know if you've heard about hub and spoke as it applies to substance use disorders. I know they're doing this in Vermont, they're doing this in Baltimore. It's a great model in substance abuse treatment. What you do is, we all know there's a paucity of specialists in substance use delivery. So you take your highly trained addictionologist or psychiatrist who's ever delivering that care, and they become experts, the consultants to the rest of the network, the primary care network, and very accessible and available to the medical network, which are the spokes. So the hub are specialists who don't see patients one-on-one for long periods of time. So for instance, in substance use, what they'll do, let's take the opioid crisis, they will possibly do induction, stabilization, come up with a treatment plan, and then the patient is referred out to a spoke. And it's often a primary care practice. and then they can see the next patient. So what we need to understand is the one-to-one no longer works in specialty. We need to become consultants, teachers, mentors, and population health specialists. That's where behavioral health is really going to shine if we do it correctly. And that enforces the hub and spoke piece. You want to work to top of license, so you don't want your psychiatrist doing a lot of work that they're not trained to do. You don't want therapists who are highly trained doing administrative work. You really want people working at the top of their license to become more efficient. Diagnostic codes. Be sure you code correctly for everything you do, because remember, value-based payment is based on risk. Risk is determined by codes. So it's very important that people code appropriately. Access is key. Start thinking about all the ways you can reach out to patients. Patients can get care without one-to-one visits. And this can be highly effective, and the research is behind it. And the numbers are in. So telemedicine. Can we really improve our access to patients, especially in rural areas, patients who can't get here? Telemedicine is extremely important. E-visits, e-programs. There's all sorts of programs now coming up to help patients with therapy. You have to be careful when you evaluate these programs, but they can be tremendous assets for patients in self-management. Bundles and episodes are a way of possibly getting into value-based payment. Certainly there have been bundles around, bundled payments around medication-assisted treatment. But it's really good to think more globally if you can. There's a lot of opportunity in larger global payment models. And think about providing high-value, whole health care to people with complex mental health and addiction conditions, again, in partnership with ACOs, hospital systems, patient-centered medical homes. So it's really about thinking how you're going to partner with the medical system so that you are an integral part of medical care, not someone out here that people say, well, your behavioral health, go here. So that's the important piece of integrating care and why that will support value-based care. So this is the little piece that I show when you think about efficiency. We integrated behavioral health consultants into primary care and made that those primary care practices were far more successful in their value-based contracts once we got behavioral health in there. So if you think about medical and behavioral health networks coming together, it increases the efficiency of the primary care physician, right? So primary care physicians are very nervous about behavioral health. They don't feel competent, they don't feel trained, and they don't have the time. They know it's there, but if I don't ask about it, it doesn't exist. In the value-based world, that's no longer true. The primary care physician is responsible for a population. And there's a real recognition that I will not be successful with my population if I don't address those behavioral health components. How do I become more capable of that? There aren't enough specialists in the world to take care of all the problems that are in my patient panel. How do I do it? And it's really about integrating and being available to primary care on a consultative level. So if you increase the efficiency of the medical provider by integrating that care and coming up with innovative ways of supporting that provider can increase the capacity of their panel. If they can increase the capacity of their patient panel, they will be far more successful in value-based models because they need to be large enough to be successful. We give them a level of efficiency that they cannot realize without behavioral health integration. So even if they're going to spend money on bringing in, for instance, a behavioral health consultant, in the end, their efficiency is going to give them success in their value-based contract, such as better quality metrics, less emergency room, less hospitalizations, and in the end, they're going to have shared savings from it. Also, they're going to feel better about what they do. That really is the ticket for value-based contracting. So, I think we're good.
Yeah, you did great.
Okay, thank you.
Thank you.
So we on purpose built in time for the audience to ask questions. So with the keeping on track.
Wanted to ask for clarification first from Dr. Feld about your pilot with your 5,000 lives. It's what are those 5,000 in your full footprint from Buffalo to Schenectady?
No, it's Schenectady, Rochester. Yeah, it's all of our members from Rochester all the way up to the Capital District.
So those 5,000 individuals that you're working with.
Those are our HARP members.
And is it only those members, or is it a broader pilot?
The pilot is for the HARP membership.
Yeah, okay.
We're anticipating it's going to expand.
And so your social determinant of health CBO
Mhm.
partner
Mhm.
is multiple different ones in that whole footprint, geographic footprint?
That's
or
a
do you
great
have one?
question. Right now, we are partnering with one. We hope to bring in more. And what we did was look at an area with our greatest concentration of those members. So that tended to be in the Westchester area.
And were you able to go to the CBO because that CBO knew that they were already providing social determinants of health services for your membership?
Yes, yes. So although there was no contracts,
Yeah.
that CBO was very open to this kind of work, and we're interested in getting into
Yeah.
this space.
But they knew that they had in their food pantry, soup kitchen, shelter, your members, those 5,000 folks. Did they know that?
Yeah, because when we looked at the data, we found them. It was kind of
Okay.
backwards because we knew that was going to be a place where we would find some of our members. Great question.
I have another one, if nobody wants to. I'm thinking, I have another one. I'm interested in, Sylvia, how you took your evidence around what we traditionally do in the child welfare, juvenile justice field around prevention of placements, and what you had to do to add any kind of value impact around healthcare outcomes or healthiness as it relates to primary care use rather than ER use in preparation for some MCO contracts or agreements, because typically that's not what we have tracked in evidence-based work in those systems. So are you now tracking other kind of healthcare outcomes as an intro to
Yes.
managed care kind of stuff?
So yes, we started the data collection first and then looked at our data to see where we were. It kind of happened that way. So when you hire on an evidence-based practice, you hire on an external body that does your data collection pretty much for you, and then they report it back to you. And so when in 2000, we started doing this work in 2000, and so in 2000 and 2003 and 2000 and up to 2008, we began to notice that that not only did we have a pretty complex behavioral health group, or a pretty complex juvenile justice group, or a pretty complex preventive group, that behaviorally health-wise, that they also had some pretty significant physical illnesses. So all of our practice is home-based work. So we were in the home, and we were noticing that they weren't taking their insulin when they should, and so we come back to consultation and go back and say, so let's figure out how that plays in your use of ER visits, etc. So we began collecting information on here are the number. It turns out that about a third of the families that we serve have either diabetes, asthma, obesity, chronic renal failure, some of the major chronic illnesses. We're the only ones in the home, but we're the ones in the home creating organization, which is what we're doing in the preventive ward. We're creating organization on the way they live their lives and how do we help them. So I just want to back up just a second. So when you have a mental health illness in the home, or you have a substance use problem in that home, it creates a barrier to just about everything else that you need to have done. So we try to work at stabilizing those two pieces first and then help them then organize everything else. So we go in the home, create the high risk factors, and then go outside and generalize it. So it's generalizing it out into the community where we realized all of our physical health, chronic medical health gains. The models are very, very strong substance use treatment interventions as well. So we noticed that probably about 40% of the folks that we were serving had a sibling in the home, or had an adult in the home, or both that were experiencing substance use disorders. So we then went about, our therapists or interventionists, whatever we have, do substance use interventions in the home, and we're able to get that stabilized so that the rest of the family can get all of their care. So for preventive folks, our job is to make sure that they have Medicaid, active Medicaid, and they have an attached primary care provider. So those are some of the first things that we do in preventive care. And I will say this to you also, that all of our preventive, and this is a sort of a secret but not, all of our providers in the preventive services world, because they're Judith's high-cost families, like they're in and out of that system like crazy with a lot of the chronic physical problems. All of our providers are licensed through our Article 31, also our mental health clinic. So they're providing Article 31 intervention right in the home. Happens to be functional family therapy or what have you. So we're able to track through psyches all of our gains.
Are you billing?
Yes, ma'am, I am billing. Yes, ma'am, I am, like crazy.
I think the last time we talked was trying to figure out how to do that.
Okay, well, I'd love to chat with you because it's super easy.
Oh, good. I'd like something to do.
So I have a couple questions. The first is for you, and then it's sort of for Chris as well. So I heard you say that your average work with individuals was for about 4.5 months before you, and you were talking about individuals with SMIs and substance use problems. So is that just your portion of the work, and then you refer them on to some ongoing? Because certainly, like somebody who might have a psychotic disorder, I find it hard to believe that the work would end at 4.5 months. So I guess I'm just curious about, what your process would be.
Yep. And so, what we have found is that, so like for example, bipolar disorder.
Right.
So we get a lot of our clients come in from hospitalizations, and they come in with a bipolar disorder. They come in with mood disorder, non-specified. They come in with depression. So all of this sort of whole group of things, and then they're on a cocktail of medication. And so the evidence-based interventions are so I want to say intense, but not in the way that most people think intense. So they are very clear, very intentional interventions that may happen once a week or may happen a couple of times a week, but they're so intentional that our psychiatrists feel safe in titrating all of our folks off their meds so we can actually get an idea of what they're dealing with. And what we find out is that when they're off meds and they're out of hospitals and their family's stabilized, gee whiz, they don't have a bipolar anymore.
Okay.
Right, and so we find a lot of that, and I would love to. I wish I'd brought it with me. We've kept a list for 10 years now of the diagnoses and medications on folks who are referred to us, and what that looks like on the exit. And so our folks exit with less than 8% of them on meds. So yeah, they do have psychiatrists that are attached to them, and usually they're our own psychiatrists that they stay with because we're populated all over New York City. But most of them don't have that need, and most of them, the family is now able to manage whatever that disorder is. But they know where we are, so if they need, if they need a little something, they come back, and we do what are called boosters. But that's sort of how it works. And in the one where I showed you the 365-day outcomes, where the variance was so great, many of them so we've had to do two things with many of them. We've had to get them a stable primary care provider, and then we do have a psychiatrist who does their med administration.
Okay, thank you. And then, Chris, you were talking a lot about how you began to see yourself more as a healthcare provider as opposed to maybe a behavioral health provider. I'm curious what that partnership looked like in terms of the medical or physical aspect of things, in terms of other agencies that you were working with.
Yeah, it's interesting because one of the difficulties we now have with our staff face is that they now see themselves as a integrated healthcare provider, but nobody else does. So they still don't get called back by physicians or primary care practices or whatever. So it's one of those things that we now think it needs to become part of our strategic plan, is how do we then begin to influence the communities they're working in to do that. So that's been very much an internal change rather than an external change within the provider network. If that makes sense from what you were asking me. I'm not quite sure whether you're asking something different.
And if I could just piggyback, Child Welfare Agency for 135 years, 142 years before we decided to become a integrated healthcare system. And and the Administration for Children's Services is our funder for all of the child welfare stuff that we do. They still don't see us
No.
as an integrated healthcare system, although they rely on us to do the behavioral health work in the home, and they rely on us to do the chronic care or the chronic health condition monitoring in the home. But they still see us as, you're a case planner, and you're a case manager, and sort of those sorts of things. But that's fine as long as they give us the business.
That's right.
So
We just had a
that's
licensing visit across our agency, and part of the criticism we got from the licensing folks was, well, this is residential services. You should be focusing on the housing, but our staff are talking about healthcare, et cetera, et cetera. So we have to take that with a pinch of salt and hope that they catch up with us. As long as they give us the license to keep on going, we're okay. But it does cause unintended consequences that you can't ignore, because that gets in the way again of the staff being able to do what they need to do. It's a matter of understanding at an agency strategic level rather than the saying to staff you just need to be integrated healthcare providers, because that.
So Chris and I are part of a behavioral healthcare collaborative.
Okay.
I'm only mentioning this because I think ours is a relatively unique one in all of New York State. And we chose to have the hub of our behavioral healthcare collaborative are 3 FQHCs. So everybody, when we're fully integrated and in operation, the centerpiece for our organization is going to be the primary care provider, and we're going to be the subspecialist providing services to the primary care provision. So to follow Judith's strategy, our primary care providers are going to become so much more effective because we are their subspecialists in substance use, in trauma, in PTSD,
Right.
you probably all heard this. I was fascinated by this, but we're going to go right after this one rather quickly, is that they did a survey with primary care providers, pediatricians, and asked them how many of them asked their new mothers if they're suffering from depression in the first few weeks of pregnancy. And all of them said, none of us do, because we wouldn't know what to do with them if we asked the question, right? How horrifying is that? So that's what our behavioral healthcare collaborative is going to be able to do. The doctor's going to ask, and they're going to say yes, and they're going to say, hello, Sylvia, I got it. And my answer to access in New York City for the families that we serve is not that they're going to come to us. We all go to them. So we provide the service right in the home. They're going to say, I got a parent, I got a mom who's depressed, that is thinking about killing herself, and 24 hours I'm in that home providing service.
Are you going to be an ACO or IPA in that little collaborative?
We don't know. We don't know. And I'll tell you really quick.
We'll let you know when we know.
Yeah. So we're starting with an IPA because it's the quickest thing to get to. And we were actually, I think it's a fair conversation for us to have with all of you. Chris and I were having this conversation that once we figure out what we are legally, and Judith was talking about efficiencies, how efficient is it going to be for us to have 11 Article 31, 28s, or 32s with a whole separate administrative structure who are legally bound together? Wouldn't it make more sense if we just had one and we all came under that one administrative structure? Well, that scares the hell out of me because I'm the biggest in New York City. Am I bigger than you are? Because I'm not coming underneath you. Right? Because like
mergers.
Exactly. But I don't want to do that. I'm not going to give up my identity to go work for
After
Chris.
150 years.
150 years and the sisters would have a fit.
Exactly.
No, but I'm teasing. But that's I think those are the conversations.
Yeah.
You know, we have 11 network partners who all have large organizations.
Right.
We could
We were talking
How do you
earlier
do
on
that?
that one of the things that I began to puzzle over a number of years ago was the fact that missions are almost more important than making sure the people we serve get better. And our missions sometimes get in the way of that. I mean, we were just saying if this was for profit, then you wouldn't have 11 organisations.
Right,
You'd
we'd
merge
all
and
be
just get on
Google,
with it.
right?
Because that's the best way of getting at
Yep.
providing services. So I think to some extent, we this is a bigger philosophical discussion, but I think to some extent, mission-driven agencies have it upside down a little bit. As long as the mission's being held accountable, it doesn't matter whether the outcomes are any good, because as long as the mission survives and the board survives. That's not the way it should be, and I think, anyway, you've heard me, you understand what I'm saying.
So just wondering, Dr. Feld, if a behavioral health provider or network of behavioral providers came to you with the data that either one of these organizations had, showing results, and said, we want to contract with you for these patient lives, what would your response to them at this point be? Would you?
A value-based contract?
Mm-hmm.
I think we would explore it, and we would explore it in conjunction, because we have a lot of other, we have a lot of value-based contracts. You probably heard my colleague, Dr. Gascon Cupid upstairs, talking about the value-based work that we're doing. How can we bring behavioral health providers into that value-based piece? And that's what we'd be very interested in knowing and exploring. And maybe you already have relationships with medical providers and other arrangements. So one of the challenges are there's a lot of value-based contracting going on right now, and how does behavioral health fit in?
Right. Or
So,
the social services. And
or social, exactly. How do we make this all work together? Because we all know on a global level that if we can get it to work together, it's going to be a win-win for everybody. And especially the patients. We're going to have better outcomes. So it's tremendous interest, and possibly working with a behavioral health organization coming to us and saying, how can we incorporate that into all the work we're doing across the care continuum? So,
And is there a minimum population size that you would need them to bring for you to work?
the minimum population size that is usually quoted for taking risks, the absolute minimum is around 2,000. I think it's really healthier when you get to 5,000. But remember, if you merge in your risk with medical providers as well, you've got a much bigger expanded base.
One present company accepted. One of the things I found when we started working with MCOs is MCOs don't know what to do with people with serious mental illness. They don't have the experience we do. Mm-hmm. So I think not only is there interest, there's also interest, you can help us because we don't know what to do with these people. So I think approaching MCOs shouldn't be something that you're leery of. It should be something that you're the expert. You know how to change somebody's behavior to improve their health care. The MCOs, present company accepted.
No, absolutely.
Don't. And I think
Right.
that's the huge. But
if
huge
you can
leverage in
approach
health.
it with
Education right now is though the data, having
The
some
data.
information, and I guess I would have been concerned coming with self-reported data that the MCA would have been like, I don't trust this data or something like that.
But the MCO has your data.
Yeah. I mean,
So we can look at your data and work with you and say, do you want to improve here? Do you want to make changes here? We have willing partners. The MCO is going to be very happy with that.
And you're not looking at a finished product. I think you're just trying to open the door, and that's
Yes.
journey's a first step and all that sort of stuff. So having some data about one program that maybe is only 3 months old but shows something is better than a lot of people and can open doors and get you to have a discussion about. So maybe it's not risk-based, but it's, would you fund a nurse working within our supported housing program? Because if we believe we have a nurse within our supported, I'm making this up as I go along, in our supported housing program,
Sounds
we
good, I'm
think,
writing it down
right,
as you
yeah.
go along.
we think we could prevent 27 hospitalizations for your members, and that would save you money. So that's not a risk base, it's a conversation about can we jointly change the healthcare and save money. And it's a pilot, this is an experiment.
Can I just say one thing to yours? So I participate with Open Minds. I don't know if anyone in this room gets the materials. So a little while ago, they had this absolutely lovely thing called your value-based payment playbook. And you go, and they ask you a bunch of questions in the playbook about who you are, what data do you have, how do you know you're ready, what do you think you do really well? Jim Collins calls it your headshot concept. What are you most passionate about? What are you best in the world? And what can you afford to do? And you put that together in a playbook, and then you go out and look at the MCOs and see which ones line up with what you do, and where are their value-based payment arrangements already. So we did that. We put our playbook together, and we sat down with WellCare. And we said to WellCare, here's who we are and here's what we do. WellCare didn't know me from anybody. And we had this conversation. I said, I know this is what you're doing, I know this is what you're doing. So they said, they said to me, would you be interested in looking at our high-risk pregnancies? Because we think what you do would line up beautifully with our high-risk pregnancies. And we do a level 3 arrangement with you if you wanted to do that. And by the way, would you also look at our complex behavioral health substance using people that are ones that we're having trouble keeping out of residential placement.
Right.
And so they said, would you do that? And we were like, we'll write you proposals on those. And so we've worked it like that, but know you first and know the why. So I sell them on the why because my story's a good one, right? I do what I do because I killed people, right? I don't want to kill people anymore. So I want to do this stuff over here. And they buy that. They buy what I do or why I do it, not really what I do. And then I get to talk about data with them. So do the playbook. Look at Open Minds Playbook. It's fabulous. It takes you right down the path of exactly the conversations you want to go have with Judith.
In our sector of the state, we had pretty significant state-run institutions for acute psychiatric as well as clinical psychiatric care. Do you have those in your area? And if so, do they create any kind of contracting or dysfunctional relationship?
You're looking at her and me because I'm all kinds of excited. I want to answer your question. Well, maybe you're asking Judith the question.
I mean, we find it very hard to move to another level when the
There's an
state's
escape.
own organizations are wanting to keep things the same way as they always have been, and they're not looking to
Yes.
make some of the changes that I think we're headed down a great path here. But when the state's own entities are holding on to their past,
Yep.
and you can't make headway against them, all of that has to be a factor in the equation.
Yeah, you are absolutely right. Yep. And we have worked, so we're with you. We're working in New York City on closing the Bronx Psychiatric. And we've been working on that for 5 years. And we finally got them to agree with us that it's time for us to come in and pull all of their psychiatric folks out. But you have to, kids, so we're proposing a multi-systemic therapy psychiatric where it takes them at the emergency room when they're headed in, or it takes them out on, but what you have to keep in mind is, this kills me to say this, your ears, this is an industry, right? And their biggest concern is, what am I gonna do with my staff if you shut my doors?
Right.
And I'm negatively reinforced to engage with you, but if you, so we've gotten some ground in just putting that on the table. When you saw the juvenile justice numbers go down, we closed 28 facilities in upstate New York. What a disaster that was for upstate New York. What a gain it was for everybody else. But we had to work through every bit of that to get them there. And I have a meeting with the woman who's in charge of the long stay residentials at the state of New York next week to talk about that. Because if they don't give in, it's gonna be really hard for the rest of us. Yep.
Yeah.
So I will give you my business card and we can probably double team them. Because I think that's the only way
Be glad to.
we're gonna be able to do it, right? We're gonna
I
have to
might
double
be
team.
able to find some volunteers.
Very good one, so we'll quadruple team them, but we'll get that done.
Yeah. I think that's really interesting, sort of like your state inspectors coming to
Yeah.
your thing and saying, don't pay attention to healthcare, your housing. Did
Right.
they not read Jason's report around supportive housing
Yeah.
and the impact and reduction of ERs?
Silos.
These are
They're
state
silos.
agencies that supposedly all report to the same governor with this agenda.
we-
And
we,
yet we don't, and it's just like prisons, right?
Remember, it's
Prisons-
just like
prisons
child
for
welfare,
upstate
right?
Our prisons for upstate is an economic development vehicle.
Yep.
So we understand that,
Yep,
but it's the same thing, but we're about a movement according to Jason last month.
Well,
right?
we're opening a healthcare facility in East New York in the next 4 or 5 months, and we're placing our Article 31 next to an FQHC. Another agency is going to be doing that. And we were working with DOH to have a shared waiting room, but DOH would only give the FQHC a certificate of a CON if there was a wall between our facility and theirs, so nobody who was leaving in an emergency, leaving our Article 31 could go through their FQHC in an emergency. So we've had to build a wall between the two.
It makes you feel like the folks that from state health that have been doing this across the state conversation, like all the trainings with
Yep.
value-based growth, they should be doing it in-house to stop and do it up and down their floors, or run over to OMH and do it up and down
You
their
know-
floors.
That's admitting that they can take away some of the jobs that they've had. That's a
Well,
big
that's
political
a
challenge.
real
Change
struggle
the
now.
model of service, you know, the people, folks
But
are
we
still to
can't,
be
but we
served.
can't wait for that. So we gotta
We
move
can't
it
wait.
going, we can't wait, we've gotta show them by persistence and persuasion, and, because we can't wait for, that's a huge system. New York
Yeah.
City ACS is 6,600 staff. We've been providing evidence-based services to them for 10 years. The turnover is such that that 6,600 staff never catches up with me. So I go in and train them 5 times a year, because otherwise I have to wait for them to catch up. Can't do it, right? So we don't have to, I hope we don't have to wait for them.
You can't
we'd
wait,
drive
but
ourselves nuts.
I will say that the state is trying to make some inroads there. For instance, we have the regional planning consortiums where, you know, each region has representatives from stakeholders, including, you know, managed care organizations, providers in the community, and looking at some of the regulations that are not serving these new value-based processes, such as regulations that are too onerous or too siloed, how we can really do credentialing for integrated clinics that makes sense and that isn't more of a barrier than a support. So those conversations are happening. I'm not saying they're going to change quickly. We all know that things don't change quickly when it comes to this, but they are currently happening. But to your point, we don't want to wait until they happen. We've got to work parallel to that.
Can I change the subject?
Sure.
Dr. Feld, how does MVP integrate, I'm from a private primary care practice.
Okay.
How do you integrate behavioral health into primary care?
Well, what we're embarking on that right now. In fact, in addition to the value-based pilot we're doing with Beacon, this year we're going to start bringing in more case management, behavioral health case management, so that we can work directly with primary care and start building collaborative primary care, some integrated approaches. So that's on the dock for this year.
So are you using an Article 31 type of an approach to it, or are you using something different, like psychologists, psychiatrists, and social workers as billing agents versus
We're
the
not
31?
coming with a top-down plan.
Mhm.
We're going to bring care management in first so we can start working more closely with primary care, but we're going to look at our provider networks and seeing what works for them. How do we approach it based? Because every culture is different. We know medicine's local. What's going to work in Rochester probably isn't going to work in Westchester as well. So we're really taking a more tailored approach.
That's been the challenge for us when we've had conversations with MVP. You've traditionally had the medical silo, and you've got Beacon that has the
Right.
substance and behavioral health silo.
And we're changing that.
And
That's correct.
you really have never connected very well.
That's correct.
And you credential differently,
Yep.
and you credential different levels. And if you're doing an Article 31 credentialing, it includes an entirely different credentialing level.
Correct.
So trying to work through the dynamics of that without the confusion that exists as to who does what when
Yes.
is a real challenge
Yes.
in something like this.
Yes. And that is the work that's facing us now that we're actively working on.
Okay.
And I can give you my card.
So I will open the door for one more question, and then I'm going to do a couple closing remarks from my script so that we can make sure that everybody's keeping on track.
I have a comment more than a question, and maybe others in the room can give your thoughts. I'm part of the district program for a hospital, and we are participating in the 3AI program, which is the integration of behavioral health and primary care. And so we're doing the Model 1 and the Model 2, and I think everybody has a pretty good handle on the Model 1. We're kind of at the co-location phase with our behavioral health in our primary care clinic. I'm just kind of wondering, given the current payment model and the fact that most organizations aren't that far into value-based payment, is anyone having any level of success with the Model 2 of taking a primary care provider out of an office where they're generating RVUs and moving them into a behavioral health clinic where, it could be hit or miss in the amount of business that they're receiving in a day. Is there any?
Can I answer that one first? Hi, Sarah.
Hi.
So as an embedded resource for St. Peter's Health Partners, right, we have participated, they have participated in both Model 1 and Model 2, and have done a really sort of deep dive on the return on investment for both 1 and 2, and are now have done a complete shift and are focusing on expediting Model 2 for that exact reason.
And that's already happening. A number of organizations are already doing that.
Yeah, we've been doing it for a while, but it's incredibly difficult to have enough volume within the medical side to make it financially viable. And just the co-licensing issues are tremendously difficult to overcome. We were lucky we had a SAMHSA grant for 5 years that supported it. We had some tremendous outcomes, but the economies of scale, I think, are very, very difficult for us.
Right. We have an RN in all of our behavioral
Yeah.
health clinics, and
That makes sense.
really has
Yep.
done a
Yep.
lot for us. But
Yep.
Yep.
We have a PNP, or a psychiatric nurse practitioner in all of our clinics.
we're in a very rural area where we're struggling to get primary care providers in primary care,
Yep.
much less moving them into our behavioral health clinics.
It's the same in
So
the-
telemedicine could really be helpful with that.
Right.
Yep.
Really helpful.
Thank you, everybody.
That was a great
That
way
was
to end.
so
Thanks,
much
Sarah.
fun.
Alrighty. 12:45. Close. What a great presentation. No, I won't really do that. So just FYI, for the folks who have been to our earlier VBP workshop, and then again to this one, this is